Oh no, I just fall down and need to rush to dentist urgently.
Oh no, you got hurt. Let me check you. Oh, it's a mandibular fracture. Yes, you guessed it right. Today's topic is mandibular fracture.
Hey guys, our today's topic is mandibular fracture. It is a very important topic from the exam point of view, especially for the final year students. So, mandible, it is the largest, heaviest and strongest bone of our face. But it is very prone to injury. And why it is very prone to injury? Because it is in the most prominent position in the facial skeleton. Now its body is horseshoe and parabola. This is the anatomy of mandible. Here this is ramus, this is the body of mandible, and this is the angle of mandible between the ramus and body of mandible. This is condyle, this is sigmoid notch, this is coronoid process, and here it is mandibular foramen from where the mandibular nerve passes. This is the alveolar process, and this is the glenoid fossa, and this is the articular eminence which we study in TMJ. Now, body of mandible is horseshoe and parabola. The angular curvature, this angular curvature is 110 to 140 degree. Mandible is compared to archery bow. Why? Because it is strongest at the center and weakest at the ends. Okay. Now, so blood supply to the mandible occurs via two systems. First is central blood supply and second is peripheral blood supply. Central blood supply occurs via inferior alveolar artery, whereas peripheral through periosteum. It is very important that periosteum should be intact to maintain the collateral blood supply. Now, if mandible gets severely atrophic, what happens? Then mandible becomes more dependent on the periosteal blood supply. Okay, so periosteal blood supply is more important in these cases as compared to central blood supply. Therefore, during the open reduction, stripping of the periosteum should be minimum. Nerve supply. Inferior alveolar nerve supplies the mandible when fracture occurs. And if damage to nerve occurs, then anesthesia and paresthesia of lower lip of the affected side happens. So eventually these nerves get regenerate and it takes time of approx 3 to 12 months. Rate of recovery of nerve depend upon 4 factors. First, proper reduction of fragment. Second, elimination of infection. Third, proper fixation. This prevents undue mobility. 4. Absence of any intervening hard and soft tissue in inferior dental canal. Muscle entrapment in fracture line or foreign body or bony fragments, because this can lead to increase in the displacement, or this can lead to wider displacement of the muscle action. In this we are going to study how various muscles are going to displace various fragments of mandible after fracture. First, muscle of facial expression. It has no effect on the displacement of fragment. Second, mylohyoid, geniohyoid, genioglossus, anterior belly of digastric. They exert effect in centripetal manner, due to which the fragments tends to collapse in posteriorly and medially. Now, lateral pterygoid. Lateral pterygoid muscle is inserted in the medial fossa on the anterior aspect of condyle. When condylar fracture occurs, the head gets displaced anteriorly and medially. The head gets displaced anteriorly and medially, and also sometimes lateral rotation occurs due to spasm of the muscle. Now, fourth muscle, depressive group of muscle. Mandible anterior to the anterior line of muscles gets affected and gets displaced by the depressive group of muscle. Now ramus, elevator group of muscle affects the ramus. during fracture, and it displaces the ramus part of the mandible after fracture. Now this is a diagram. This is lateral pterygoid, medial pterygoid, and this is the displacement. Now factors influencing displacement of mandibular fracture. There are total 6 factors which affects the displacement of mandibular fracture. First, direction and intensity of traumatic force. If the force is strong, then in two-way fracture occurs. First, direct fracture will occur, and then on the opposite side, indirect fracture will occur. And this will lead to displacement of the fragment. Muscle pull on fragment. As we studied before, that different muscles affect the fragment and cause their displacement. Now, site of fracture. For example, if the site of fracture is the ramus, then we know that ramus is splinted by masseter and medial pterygoid on both the sides, due to which even with the presence of extensive comminuted fracture, there is minimum displacement of the fragments. Now, direction of fracture line is other factor. Extension of soft tissue wound, severe tear of musculature and soft tissue. This leads to wider displacement of the fragment. Now, presence and absence of teeth. If teeth are present proximal to the fracture line, then they prevent the displacement of the fragments by occlusal contact with the maxillary arch.